So thank you for joining us today. My name is Neil Sutton. I'm here with Todd Milne, Director of Security Operations, University Health Network, Noreen Milne, Manager of Security Services at Unity Health Toronto, and joining us via webcam, Martin Green, Manager of Security, Telecommunications, and Emergency Preparedness from Baycrest. So we thought we would get some folks from the healthcare security sector together just to discuss some of the issues that are impacting us due to COVID-19, particularly in the healthcare sector. So I'd like to thank everybody for joining me today. Maybe we could just get a question out of the way. How are hospitals actually handling this crisis? Are they dealing it with on a case-by-case basis? How have hospitals moved into crisis mode? Martin, do you want to kick us off?
Sure. So Baycrest, though, is not an acute care hospital. We're a rehab hospital and geriatric care and a long-term care home. So we initiated lockdown procedures a couple of weeks ago and began screening. And I think other hospitals weren't as quick onto the mark or weren't required to. We had a directive from the ministry to do that. So we've been in lockdown mode for 2 weeks. We've reduced the number of entrances. We've reduced the number of visitors. We have a number of staff that are working from home. And we see that for the foreseeable future continuing.
Thanks, Martin. Todd, maybe you can just share some thoughts on that, please.
Right. So really, it's the same thing. I mean, we're all following the ministry directives for sure, and it's definitely not a case-by-case basis. I mean, we're still trying to operate our urgent services. For example, our cancer care services are still moving forward, despite some of what may have been heard in the media. So some of those surgeries that are necessary still need to be done. Some appointments are still kept, radiation appointments, etc., are still being kept. So there's a fine balance between still operating your hospital and still keeping secure entrance points. And what really made it a challenge, of course, is when the directives of having a no visitor policy. That's what makes it more challenging. Most people hear the media and they understand the no visitor policy, but not everyone does. So we get greeted at the door with visitors very confused as to why they're not able to go in with their loved ones. And with that, it's assessed every time for compassionate reasons. What's the rationale for accepting the visitor in and possibly bringing in more contamination? We're trying to keep our environment as clean as possible, and less is better. More controlled entrances is better as well too. I would like to see even more of a control over our entrance areas, but that's really the big challenge for us. I mean, we're operating anywhere from 3 to 4 entrance points. I'd like to really go down to 2. We'll see how that moves forward as each week progresses. I'm feeling that over the next couple of weeks, our numbers are going to increase and our directives are going to change as well too, and we're going to have to be very proactive in our planning.
Thanks, Todd. Maybe Noreen, can you just discuss what's going on at your hospitals right now?
Sure. So it's pretty much the same thing that Todd and Martin had mentioned. We're doing the same things where we've limited access into our facilities, where we have a no visitor policy. We're at times still, I guess, running into those same challenges of either people not getting the message from the media, whether that be they're ignoring it, or they try to come and circumvent it, or even a lot of people don't have access to I guess don't watch TV, so they may not understand that the importance of not coming into a hospital and potentially bringing the spread of this virus into the hospital. The other thing that a lot of hospitals have done, and along with us, is that we've created assessment centers specifically for the COVID-19 potential patients. Anyone who is suffering from any of these symptoms would end up going to this assessment center that is usually either on the other, in a remote part of the hospital or close to the hospital. And that really has helped us in sort of separating and trying to keep the hospital, like the internal hospital, as clean as possible. So that's one of the things that we've done. The other thing that a lot of hospitals have done, including ours, is creating COVID-19 specific units. But then that also creates other challenges, such as how do our staff respond to calls such as duress calls or staff assist calls, or what we call in hospitals code whites. And trying to figure out, or trying to put to some specific guidelines to respond to this type of a virus, or those types of patients, has been, I guess, a learning curve for all of us.
Thanks, Noreen. Can we maybe talk a bit about pandemic planning and how those pandemic plans have now been implemented? I mean, I guess lessons learned from SARS and H1N1. How are those pandemic plans now coming into play now that we're in another real situation? Todd.
So with reference to pandemic planning, what I find really interesting, and I'm not too sure about the other hospitals, but I believe, so when we had SARS, we actually went into a code orange, which is an external disaster. And here we are today with COVID, and I'm not aware of an actual code orange that has been initiated. I mean, I understand, of course, that we're in a disaster state, but we haven't actually activated our code orange plans. Like, we have and we haven't. It's interesting, like I said, because we still have a relatively the same response, but we just haven't gone by our code orange planning, even though some of the initiatives that we've taken are very similar and just the same. But looking forward at our planning, I think where we have to be right now is, so we're at a spot now where we have a general understanding of what needs to be done, and we have an action plan, but it doesn't stop here. If we're going to continue on with that pandemic planning, we still need to plan for the worst. So for example, we need to look at our hospitals now. We need to find areas that we can expand in our patient care, our inpatients. We have to start looking at those spaces that can be quickly transitioned into a patient care area. It could be, example, it could be a food court. It could be an empty conference space that you might have, and how can that be transitioned into bringing in more patients into our hospitals? We can surmise that this is going to continue. We take a look at New York, for example, and they're bursting at the seams, and that's not where we want to be. We want to be ahead of that, and I think if we start planning for that now, preparing for that piece, that will go a long way in addressing our pandemic planning.
Thanks, Todd. Noreen, how are pandemic plans being implemented right now?
So I think with I don't think we could have foreseen such an event like we're experiencing now, with things that are just closing, and the type of mandates that the different levels of governments have I guess filtered down, such as this, as we were waiting for this call to start, or the seminar to start, everyone ended up getting an alert on their phones. So this is really unusual, but I will say that our pandemic plans, I think, have given us a jumping off point of how to really handle our this event. And I think even with our experience with SARS, we learned so much from that has helped us. Now, mind you, I think that our pandemic plans will continue as they are right now to evolve and try to respond to this event as best as possible. But it is I've found that our pandemic plan is and should be a very fluid document that we can reference.
Thanks, Doreen. Martin, how are your pandemic plans being implemented right now?
So we really haven't kicked into pandemic planning. We're sort of on the verge of a code orange for us, because not having an emergency department, we have a different type of code orange. And for us, it's an emergency that overwhelms the organization. So we haven't declared a code orange, but we're sort of operating on that. We've shut down everything that's unnecessary. The majority of our clinics are closed down. Again, we have a lot of staff working from home, and we've redeployed staff within the organization. And we're more on a business continuity plan rather than on a pandemic plan. It's what can we afford to shut down, what needs to stay open, and how can we support those critical functions within the hospital.
Okay, thank you. How are you protecting staff at a time like this, security staff, you know, trying to remove the possibility of the contagion spreading for people who have to work in the hospital on a daily basis? Martin, do you want to address that one first?
Well, we initiated screening for all a couple of weeks ago. So everybody coming into the organization is screened at the door. And that's the first thing. Then we're concentrating on ensuring that people are sanitizing their hands, washing their hands, wearing masks and protective equipment where it's appropriate. You do see a lot of people out in the community wearing a mask, and it's not necessarily appropriate. And of course, with the stockpiles and the concerns about possible shortages throughout the province and the country and even the world on personal protective equipment, we're economizing it where we can. We're making it available where it's necessary, and constant education. And I think what's really fundamental to frontline staff, for Todd, myself, and Noreen, we went through this in SARS, so we know what to expect. But a lot of our frontline staff are new and they're junior, and this is new to them, and they're a little bit afraid. And they're listening to social media websites. They're getting information from invalid sources, and they're not necessarily paying attention to the facts. And that's the biggest thing right now, is ensuring our staff that we are doing what's right and what's appropriate and what's safe for them, and to stop listening to Facebook and Twitter and the rumors that are out there in the liquor store when they're out shopping.
Thanks. Todd, can you talk about how people are being protected in the hospital right now?
Sure. I guess depending on what area of the hospital that you're actually in. So if you look at our screeners, for example, our screeners, they have full face masks. They're wearing gowns as well too. And anything that's outside of the clinical spaces, they're not required to wear a mask, but if they are going to enter clinical spaces, they're wearing procedural masks. So depending on your involvement with the patient care really dictates on the PPE that you're going to be donning at that time.
Okay. And is it the same situation with you as well, Noreen?
Yeah, it is. And I think I'll just sort of add to one of Martin's points is I think the education piece is so important. And I agree that, a lot of our frontline staff who did not experience SARS, as we all did, they're concerned. They have lots of questions, and definitely they're scared. And unlike during SARS, unlike now, we didn't have social media, or social media wasn't as big. And so I think that's one of the challenges that we're sort of facing, is trying to debunk some of those myths, some of those, I guess the misinformation. But I think one of the other things that we're doing here at Unity Health is that we do have a lot of support when it comes to education on why we're wearing the PPE, how we're wearing the PPE, and when we're wearing the PPE.
Okay, thanks. So maybe I'll just ask.
Sorry, if I could just add in, sorry. At the beginning stages when we began screening, we just did it by social distancing. So we had tables set up for our screeners so that we maintained the 6-foot minimum. But this past weekend, we brought in booths, a combination of plexiglass booths, and our screeners now sit protected behind that, a plexiglass screen with a two-way microphone, so that they have the proper protection.
Okay, thanks, Martin. So maybe just one last quick question as a wrap up. I know this is a constantly evolving situation, and things could change a lot in the next coming days and weeks. But what are some of the lessons we can take away from this to apply to future plans should we encounter this kind of situation again at some point in the future? Noreen, do you want to maybe just wrap up for us?
Wow, that's such a it's a question that's difficult to answer, because I think every day, every hour, we're learning more and more lessons. And I think one of the main lessons I think we can learn is just being able to evolve, because it's very frustrating and very difficult at times to constantly needing to change at times, every day or every hour, every half an hour. What was appropriate at 2 o'clock might not be appropriate any longer at 5 o'clock. So I think that's one of the biggest things, is that we really need to see these types of emergencies and the response to it as a constant evolution, and just being able to understand how fluid these situations can be.
Thanks, Noreen. Todd, do you have any closing thoughts for us?
Yeah, for sure. Pandemic planning is going to take a whole new look at how we do things. The ministry is going to really take a whole new look at how we do things as well too. I mean, healthcare has always been recognized as a place that has to cut their budgets and reduce, and then all of a sudden we have something like this, and we're not completely prepared. So when we look at our preparedness, we look at our supplies, we understand our supplies are taking a bit of a hit right now. And I think if we start looking at how we store our supplies and the amount of supplies that we do store, so that we can be prepared for an event like this. And let's face it, I mean, this is going to happen again. It might not happen next year or the year after that, but this is definitely going to add to our pandemic planning, and very specific to how we stock our supplies and where we stock them and how we have access to them.
I just want to add, sorry, I wanted to add, in terms of that, it's to me, I find it really fascinating how these types of events really do sort of showcase the importance of security, not only manpower, but the systems as well. And I'm hoping that something good comes out of it, at least for when it comes to budgets for security. And it's understandably so that usually budgets in healthcare are geared mostly towards care, but I think these types of events really highlight the need for I guess for support services.
Okay, thanks, Noreen. So maybe Martin, just some closing thoughts on what we can learn from this.
Noreen's absolutely right. The need for security technology, the manpower is important, but if the more technology you have, the less manpower you need in some cases. And I wouldn't have been able to lock up my hospital without recent improvements that we've made to security. And pandemic planning, and like any emergency plan, has to be flexible, fluid, and nimble and agile. I was talking to somebody who doesn't work in healthcare recently, and they said, so what's it like working in a hospital right now? And I said, so imagine you're the quarterback for the Dallas Cowboys, and you're in the middle of a football game, and as you're playing football, the NFL keeps changing the rules on how the game is to be played. And as you're getting ready to set up a play, the coach is calling in a play from the sideline, and when the quarterback finally gets the ball, he looks up and his team's gone. So that's kind of like what we're living through right now. You've got staff shortages, you've got supply shortages, you've got the ministry changing the rules and the guidelines constantly. That's what it's like. So you need to be agile and nimble, and not necessarily rely on what's on the paper. You need to rely on what the experience is. Okay,
thanks, Martin. So I think we should wrap it up, but I want to thank Martin and Noreen and Todd for joining us today. I know everybody's really busy. Thank you all for all your great work, and all the security departments at all the hospitals across the country, and all the work they're doing right now to try and resolve this situation for everybody. But I appreciate your time and your efforts, and thanks again.
Thanks, Neil. My pleasure.
Thanks.
Thank you.
All right. Stay safe, everybody.